Thank you so much, Summer. Um, and thank you for already introducing me. I will be here, as always, to help man the chat. So please feel free to put as many questions as you have for Dr. Abe into the chat. Um, I will be passing them along kind of as you add them into the chat. And then since Dr. Abe is going to be covering a couple different topics, we'll also take quick pause after each individual subtopic to just see if there's any questions, so that we can hopefully have a nice discussion going as well. And I think without much further ado, everyone here more or less knows Dr. Keith Abe. He is our amazing peds neurologist, and he has offered to talk about everything head related. I hope you came with your questions and your learning hats on. And again, feel free to put anything into the chat or just unmute yourself and feel free to share at any time. Thank you. And thank you, Dr. Abe.
Thank you, Anna, for that kind introduction. Let me see if I can get this screen sharing thing to work. And as Anna mentioned, please feel free to chat often. I always worry that everyone's sleeping partway through these. So just hearing any feedback, questions, I think everyone will get more out of it the more you engage. So please engage and ask questions. And I already mentioned that I think I bit off more than I am able to chew for 45 minutes to an hour. So we'll just see what we can get through. And but I will rush through the end of the headache part because we went through it a couple years ago, I think. And B, some of it I think we can bypass. I want to kind of mainly cover the things for primary care. And so hopefully my slides will advance, but no, I'm not sure.
Yep, they look
Okay, good. Okay, so learning objectives, head-related things. I'm not sure about everything for the head, but we'll start it off with headaches as something that I think comes up often in primary care, and we get a lot of referrals for, and just to try to build confidence with that in the primary care setting. And then other head-related issues, talking more about things like macrocephaly, heads that are unusually large, microcephaly, heads that are unusually small, and how to approach either end of the spectrum, and then a few neurocutaneous conditions, which actually overlap with all of the first three issues above. And so, as mentioned, no disclosures, please send questions, and we'll start rolling. So just, these are questions that from the previous headache talk. And so just kind of think on your own as we go through which ones are true. More than half of kids and more than 90% of teens have some history of headache. At least 5% of the younger children and 25% of teens have recurrent headaches. And of them, about 10 to 20% of teenagers have migraine, would meet criteria for migraine. More than 3% of children, 5 to 10, meet criteria for migraine. And true or false, about 30% of adults with migraine had it start in childhood. True or false, serious pathology is a cause of more than 5% of headaches presenting in primary care. And we'll come back to these answers later. And patients want to know about how to minimize headaches and get better headache control. Which ones are true? Adequate sleep means attention to both quantity, quality, regularity. Regular activity and physical exercise is good for headache. Parents should check in often with their child about whether they're having head pain and avoid any activities that cause it. Patients should take rescue medication to anticipate a headache they might have later, and preventative medications can be used as needed to prevent headaches. True or false? And lastly, PCPs are true or false. PCPs are adequately trained to manage the vast majority of pediatric patients with headache. most pediatric patients, B, don't need neuroimaging as part of their evaluation. C, every patient with a headache should be screened for red flag findings. D, every patient with headache should optimize lifestyle habits. And lastly, most children with migraine require brain imaging to rule out other causes and triptans, which will require a neurologist to prescribe. And so the initial input for this topic previously was because in our referrals that we get for our neurology clinic, about a third of them were due to headache. And that's a sizable portion. But although we put out this algorithm to try and guide the process for headache evaluation, we're getting a lot of referrals that jumped from presenting with headache to jump to referral to neurology. And even phone, our referral notes would have phone messages saying patient called for headache, plan, refer to neurology without seeing the patient in the office. And so what we want to do is avoid this kind of reflex referral for headaches and try and walk through the process to help triage patients in terms of identifying red flags, what we call yellow flags or kind of softer signs, and then working if there's none of these conditions indicating a need for more urgent evaluation, then working with patients to try and control their headaches as best possible before referring to neurology. And the goal for all of us is to have the right patients being seen by the right provider at the right time. And so why do patients come into the complaining about headache? Sometimes it's because it's interrupting school or extracurricular activities. They can't keep up with their homework. Their mood and behavior might be changing, but it also impacts parents quite a bit in terms of their missed work, having to take care of kids. And of course, there's always lurking in the background, what if it's due to something really bad? Because we often hear about people with brain tumors. But on the, to educate parents, we have to remember that headaches are common and rarely due to serious pathology, because in those previous questions, a lot of patients have headache, a lot have recurrent headache. In fact, a lot will qualify for a diagnosis of migraine when we go through the criteria, and it helps to kind of put a label on it or put a diagnosis on it, because migraines are pretty bothersome. They're very disruptive to patients' daily activity, but they're also quite manageable. And as a reassurance, less than 1% of patients coming in complaining about headache have a serious pathology needing more intervention. So in an old case series to a headache specialty clinic, over 800 kids getting evaluated. 142 of them, or about 17%, got imaging, and less than 1% had pathology needing attention. And they were predictable by clinical findings. So again, we can trust our history and exam to pull out patients who are going to need more acute attention. And really, the tool that we really have to use, as we hear so often in training, is getting a good history. And that patients often, well, we have patients of varying history quality. And sometimes folks are very objective and can give a good story and good data. And others, whether it's by just remembering the worst thing that happened or some bad story of someone else's circumstance, sometimes that kind of clouds the information. Having headaches all the time and never goes away, and kind of remembering the worst headache of all, as opposed to the history over time. So we have to extract that history, and it starts with seeing the patient and getting a headache-oriented history, checking for the red and yellow flags. And then if there's no flags indicating acute management, then giving counseling on how to best manage headaches in terms of lifestyle habits and rescue medications that can be given. And then the key thing is to really follow up. So often we also get referrals from a one-time visit saying, take ibuprofen and refer to neurology. But on the other hand, if If the patients are doing better, there might not be much else for us to contribute in those cases. So just trying to help triage accordingly. And again, Anna, if there's any questions or chat comments that come in, please send them our way. And so if, however, with all these interventions, things are not better, then definitely we want to get involved in helping those cases. So again, starting with the thorough history, fully characterizing headaches, sometimes asking patients to keep a diary so they themselves can see the patterns that come out and maybe correlations with their daily activities or times of the week. Are they getting up Mondays and Tuesdays because they're not sleeping, Saturday, Sunday, etc. Again, the time of the day, are they morning headaches, afternoon headaches, how they're changing over time, because the pattern, as we'll see, is also very informative for us. Because if you look at these different time courses, which are really important to try and extract from the patient, because they'll, in all of these cases, they'll say, having bad headaches, and definitely there's a bad headache in there, occurring, but it makes a big difference if there's no headaches in between. Or how about varying levels of headache, not maybe as severe, but kind of constant headaches over time? Or how about never really had headaches and they're constantly increasing, getting worse over time? How about some mix of A and B, where there's always some steady background headache and some exacerbations in there? And so what would you, if someone described these patterns, I guess, what would you think, oh, I think that's representative of this kind of headache cause or that kind of headache cause? And so, so the first one is typical for migraines. So migraines are very severe, very bothersome, but pretty episodic, usually lasting hours. The second one, kind of more low grade, but chronic, kind of day in, day out, could be more tension type or more mood related type. The third group, with the persistent progressive never going away, but progressively getting worse over time, is some of the more concerning findings in terms of masses or increased ICP problems. And then D is it's a little bit tricky because there is this constant low grade headache on the background of other exacerbations, which sometimes can be a combination of migraine and tension type headaches, or what we see sometimes is patients taking pain medicines every day for months, and they're having an analgesic rebound headache in the background. So just kind of extracting that pattern, patients being able to describe that pattern can help us point us toward the differential. And so a variety of triggers can also be identified over time, and sometimes that's helpful for patients to try and fish that out of their history, because prevention is much better than treatment. So again, optimizing lifestyle habits to minimize headache occurrence. And so again, just going through the steps, identifying triggers, seeing if there's any systemic causes for secondary headache causes that are treatable, readily treatable, other medical problems that contribute to head pain. Again, really, I can't emphasize enough about lifestyle habits, because those are daily things that won't get better unless you address them specifically. So ibuprofen can help with head pain, but it won't hydrate and it won't sleep for you. So that's what I try to emphasize for the patients, that although they want a medicine to feel better, it's not going to get to the underlying cause if they don't address the underlying cause. And then their use of treatment, how often they're using it. Sometimes we have both from folks who are using it all the time, thinking just in case they might have headache that day, they don't want to disrupt school, and so they keep taking it all the time, or folks who are kind of medicine fearful and take half a dose and wait till it gets really bad because they don't want to take too much medicine, and they don't want to, and both have reasonable underlying rationales for them, but they also kind of provide suboptimal control. And then we'll get to physical exam, about things that can be very helpful again on the triage process. And another kind of nugget for migraine is that sleep is one of the few things that really, really changes the pattern of things. I'm not sure how many in the audience, probably about 20 to 30% of us out there have migraine, including myself. And sleep is a huge trigger when you don't have enough of it, and a huge alleviator when you get some. And so definitely for physical exams, there are a few things that we want to make sure is done for every patient with headache. Definitely blood pressure, of course, that they're not febrile, head circumference, which we'll be covering again a little bit later in the talk. And not that every patient needs their head measured, but they do need it measured at least a few times in their development. Again, sinus disease, and a key one is obstructive sleep apnea risk factor. So sometimes they're saying they're getting 8 hours of sleep, but maybe they're waking up, every 15 minutes, compromising that. We'll talk about neurocutaneous stigmata at the ending of the talk. Hopefully we'll get there. And then for the neuro exam, besides orientation, also mood, super important. And the one that I can't emphasize enough is a fundoscopic exam. So whether it's in your own care or by some means to get a clear look at the optic disc to be sure there's no papilledema will totally change the direction of the workup and treatment. And so super important. We do have some patients sometimes coming from the ERs, not getting their fundus looked at, but really if they're coming in for a headache, we got to know that they don't have papilledema. And lastly, gait and coordination. Posterior fossa tumors are common in kids, and so we just also want to really stress their coordination and balance. Kids 5 years and older should be able to tandem walk, and so often I'll have them do that in the office. So probably if there's a take home, I think it's things that you would already identify in your mind, but just to kind of run through the list. And one thing good about having the list is that once you know you've ran through the list, then you can kind of with confidence provide reassurance to the family. And so, of course, anything abnormal on the neuro exam that's a focal deficit, particularly with papilledema, we want to check for. And then some other characteristics of the headache pattern, either the super severe abrupt onset headache, often they call it thunderclap headache. Although I would say more often these, whether it's due to aneurysm or AVM, are presenting to the ER because that's how severe they are. So I would say it's uncommon for that type of headache to present in the primary care setting. But the persistent, unremitting, new onset headache that's not getting better, despite optimized lifestyle habits, also should raise our radar. And of course, other things affecting development will always trigger us. And so, on the other hand, if all of these things are excluded, then that's good reassurance we can provide the family. Again, for ICP problems, looking for blurring of the disc would be one of the main things early on. The other is headaches that are worsened with being in a horizontal position because of hydrostatics. That being said, migraines can wake up patients from sleep. So not every headache that awakens you from sleep is due to increased ICP, but it's more this clear pattern of worsening with being supine is helpful. Also, nausea and vomiting, common with migraine, but intractable or really difficult to control nausea and vomiting, can't keep anything down. Also has to raise our suspicion. Other things like 6 nerve palsies and diplopia and sunsetting, difficulty with upgaze are later signs, but definitely if you see them, then there needs to be urgent care. And so when we think about other things that can present with headache, a lot of them vascular, a few infectious, a few metabolic, they all have other kinds of things that will tend to catch our attention, whether it's persistent progressive, sudden severe, focal deficits, things that would help us realize that they need more testing. And so again, kind of being thorough on the exam and characterizing the headache course can really help us be confident that there's not further testing that's needed. Yellow flags are kind of softer. So one thing that should stick out to us is age and or of course other comorbid factors that predispose to serious conditions in the head, whether it's neurocutaneous, sickle cell, hydrocephalus, of course. That still doesn't mean that they can't have primary headache syndromes, but we also have to realize they already got kind of one strike against them and look at them a little more closely. The occipital, cervical, or the neck or back type is more looking for posterior fossa or Chiari-1 problems, often that are worse with cough or Valsalva, but not necessarily a strong indicator for need for acute workup. So sometimes we do get referrals saying reason for referral, refer to neurology for MRI. And so that puts us in a tough place. There's actually a choosing wisely, I guess, policy out there about not imaging for uncomplicated headache. And so Epic, if you try to order MRI for headache, will kick back these feedbacks because in studies, it's low yield and sometimes confounding to get brain imaging unless it's indicated. And so in this, again, another old study, this is out of the 90s, 300 kids getting imaging, 28% of these with headache had an abnormal neurologic exam. 3 of them, 4%, had space occupying lesions, but they all had a normal exams. So they all would have been picked up as part of this group, 89 instead of 300 patients who got imaged for their headache. So again, you can trust your history and exam if you do a history and exam. So again, we just ask for that to be done prior to referrals, and that would, I think, help the triage process quite a bit. And so again, abnormal exam, increased ICP signs, this progressive course, unremitting without another explanation. If it's just persisting progressive and new, and again, the yellow signs, yellow flags about other underlying conditions, or some strong family history of vascular or neoplastic conditions. Otherwise, when we think about more common things like viral syndrome, strep, of course, things that have other unrelated causes and treatment, and then the rare serious things that we're trying to rule out again by history and exam, then we have the primary headache syndromes, which I'm going to go through quickly, I think, for the interest of time. And of them, migraine is the biggest one that seeks kids to come to medical care, although most don't have the classic aura. And you only need pounding headaches, usually lasting hours. Doesn't have to be unilateral like parents, usually quite disruptive. So it has to be severe and lasting hours. Severe meaning disruptive, and usually you need either nausea or vomiting or light or sound sensitivity. And if you have 5 or more of these, then that would meet criteria for migraine without aura. The exacerbation with activity and being relieved by sleep, that's not part of the diagnostic criteria, but also helps, again, in the confidence with the diagnosis. Whereas the aura sometimes can be colors, and often folks say, like, oh, I couldn't read part of the page, or I couldn't see somebody's face, because you get these negative symptoms where you might have spots that you can't see clearly. Visual auras are the most common. Usually they last for minutes, often in the beginning of the headache or prior to the onset of the headache. And again, better with sleep. And after a couple of these classic types, then you would be diagnosed as migraine with aura. Other more unusual variants, which sometimes do require imaging, are ones that do have more neurologic symptoms, whether it's hemiplegic, vertigo type, or basilar migraine. So these are not that common. These definitely will probably need some further workup. But again, not a common type, but can still be an explanation for focal deficits in patients with headache. And then some earlier signs, which sometimes are the first diagnosis, or sometimes in retrospect may clue us into the predisposition for migraine, are things that manifest sometimes in infancy. So this abrupt head turning, head tilt, and fussiness. They even go as far back to say that children who manifested colic, there's a high risk for migraine in the future. So whether it's colic, paroxysmal torticollis in infancy, sometimes you have kids whose heads get stuck for a period of time and they get fussy about it. Benign paroxysmal vertigo, different from BPPV in older people where you have the head turning and your otolith moving in your canal. This is just kids who all of a sudden get vertiginous and will hold on to their parent and close their eyes because they feel uncomfortable. They might get pale, they open their eyes, they might have nystagmus, and it kind of passes with these attacks, usually lasting minutes. Often they are prone to migraine later when they get older. And then cyclic vomiting, the kids who are otherwise well in every other regard, but just have recurrent bouts of vomiting. Actually, they're treated fairly well now with migraine prophylactic type medications. Other things that tend to be common in migraine is a tendency for motion sickness. And in patients who have concussion, they have a more protracted recovery period because of their predisposition. And so in early ages, between 5 and 10, male and female are pretty similar. And then as the prevalence increases with teenage years, females outpace the males about 2 to 1 by the time they're late teen years. And by early adulthood, it's about 3 to 1 in terms of the probable hormonal effects on migraine. But they can start earlier, and males often more often in the younger age. Otherwise, just breezing through other types of primary headaches, tension type headaches, more band-like pressure, usually not pounding, and often adequately treated over-the-counter medication, so often not coming to attention unless folks have specific worries. Chronic daily headaches, so just defined as more than 15 a month. Could be 30 a month, could be 20, but a few things should stick out in someone who's complaining about this. One is how often are they taking pain medicines? And so again, analgesic overuse more than 3 days a week for more than 3 weeks will set you up for this chronic headache that is kind of low grade but never goes away. Sometimes other stressors in the environment can be contributing factors. And one key one I would say is a patient who says they have headaches all day, every day, never going away, really have to get PHQ-9 screening. And so we've had a number of patients where their headaches never get better till they get treated for depression. And one case that totally sticks out is a young girl who had headaches that never got better, and we brought up depression. She seemed depressed, and mom says, no, it's the headaches. If she only got her headaches treated, then she wouldn't be so depressed. And then she saw an antidepressant commercial on TV and said, Mom, that's exactly me. I think I need this kind of treatment. And then so ultimately got seen by psychiatry and got treated, and then headaches got better. So sometimes there's also resistance to acknowledging that mood can contribute to chronic headache. And I'm going to skip these. These are from a prior talk. So also in imaging with migraine, so it's possible that sometimes you can find these non-specific bright spots that are common in migraine that don't necessarily indicate another disease, but can complicate things in people with migraine who then get brain imaging, and then they're saying, but what about that spot? What is that spot? Why is there a spot on my scan? But there's just a higher prevalence of these lesions on people with migraine. You can also get a host of other incidental findings, which can also complicate their assessment. And so just again, we want to be judicious in the patients we image for headache. And so if we get to see the patient and we confirm no red flags, then really the crux of the treatment is optimizing lifestyle habits and providing counseling and reassurance that they don't have something that is more worrisome, addressing specifically why they're coming to see you. You know, is it serious pathology they need reassurance about, or do they need to get back into action for school? And skip this. And so it's been said in some neurologist talks that the patients will never be satisfied until you tell them that you thought about tumors and that this is the reason why we don't think that there's a tumor, and all the things that you're looked for and you didn't see. And then really educating on the importance of avoidance of triggers and lifestyle habits to minimize headaches can't emphasize it enough, but no medicine will sleep or hydrate or some will de-stress you to a degree. And so really attention to those areas is paramount. And I'm going to skip through these unless someone is asking questions. So just things that, so sometimes we'll see also notes that come through that we'll say like, are you drinking a lot of water? Yeah. Are you skipping meals? No. Um, um, are you sleeping enough? Yeah. But then we find out the patients are sleeping like 4 to 5 hours on the weekend. They're drinking, 1 cup of fluid with each meal and playing sports. They're eating when they're hungry, but they're skipping meals, or they have poorly balanced meals. And so sometimes really getting into the details rather than before checking the boxes off is really important and helpful. And of stress, huge factor, especially for our teens, and sleep and physical activity also super important for stress reduction. So can't emphasize it enough. And a huge way to really change patients' headache experience without prescribing more medicine. But also, I also will counsel them that even with perfect lifestyle habits, you could still have headaches break through. And so when that happens, we want to address it adequately. And so we want to take adequate doses as soon as you know it's going to be one of the bad headaches, whenever it's needed, but hopefully not more than 3 times a week on a regular basis. If there's a week with 4 or 5 times once in a while, that's okay. But if they're having 5 to 6 days a week, weeks and weeks, then we have to talk about preventative medicine. For me, I'm not a fan of the combination types that have caffeine or other sleep aids, and definitely no narcotics, which have been shown to actually worsen migraine. And so again, emphasizing lifestyle habits and providing acute treatment plan is an important first step, and that will actually manage a large portion of patients who are coming complaining of headache. For those that are not getting adequately treated with these interventions, and sometimes the preventative medications do have to be used, or other triptan combinations. But again, really important to address these before seeking out those. And going to go through these pretty quickly, just that there are indicated triptans for kids, which they didn't used to be in earlier years. And preventative treatments, just to gloss over in case you have patients who get started on that. It takes a while to work, and sometimes patients get confused with the preventative treatment and acute treatment. Like, do they take it when they have headache? Well, how about when they don't have headache? Are they still taking it? Definitely have to take it all the time. And the goal is to, over time, reduce the frequency of headaches. And sometimes it can take weeks. So I often tell them it's going to take 2 to 4 weeks before you notice anything. Sometimes they notice it sooner, but often I'll try and set them up with that anticipation, so that when things do start getting better, they give it enough time to work before giving up on it. And so often I'll tell folks to use a 7-day pill container, because it's hard to take things consistently. So we need to take it consistently, and then keeping their headache log. And our goal usually is to have less than a headache a week on a consistent basis, and less than 1 day a month of missed activities because of headache. So again, it won't get migraine free, but we want it to make it manageable for them for everyday work. And I'm going to jump through. Okay. Are there any questions or comments on headache?
I don't see anything in the chat just yet, but everyone, please feel free to type any questions you have, specifically around headache. Otherwise, we would move on to the next topic. But I did want to make sure that we have enough time for questions for each topic.
So head circumference, probably not the most exciting thing for most folks to think about or look at, but one of the things that we use a lot in neurology. Again, sometimes folks can get a little bit, parents can get a little obsessed about like, how's the head? And really it's just one measurement that we use in conjunction with other clinical findings, but absolute numbers and trends over time are both helpful for us. Again, so um, we'll talk about a condition that's pretty common called benign enlargement of the subarachnoid space, which often has head circumference that grow outside the 95th percentile, but will curve along with the graph and kind of re-enter at a later age. And that's different from other ones that will go above the 95th percentile and then trail off into, 3-4 standard deviations away. So both saying it's big and how it's trending over time are helpful for us. Also, if it's declining over time and crossing percentiles, even though it's increasing, that's also an important measure. And also comparing that trend of the head circumference with weight and height for the patient are also other factors for us. I think most charts only go up to 3 years of age, but sometimes we are interested in older patients, especially because of other factors, head sizes can still trend. So I think there's a Nell House from the 60s growth chart that actually goes up to adulthood. And so that can be helpful again for older children who still have abnormal trends in their head size. In general, but there's a ton of change in the first year. So often in the first 3 months, patients' heads will grow about 2 centimeters a month, then 1 centimeter a month, and then half a centimeter a month for the next 6 months. And so a lot of change early on. And so really getting good head circumferences can be helpful again for the monitoring of the patient. And so starting with microcephaly, so head size too small. And just a reminder that usually we want to measure they say a centimeter or two above the eyebrow, but I would say just the furthest part in front to the furthest part in back. Then you have to pull the tape tight. So measuring too high or too slanted is going to underestimate, but then not pulling the tape tight enough is going to overestimate. And so, errors both ways can confuse things. And so often in patients with microcephaly, their head will almost seem to cut off at the top and back portion. So you see that it's not just getting thinner, but it's getting flatter. And so that can be caused by a wide variety of problems. So in general, brain growth drives head growth. And so when head too small, then brain got to be too small because the blood and CSF don't take up that much space. So when head's too small, the brain's not growing. And so often it can be caused by infections like old torch ones that we think about with CMV and other more recent ones like Zika. We've had some pretty severe Zika cases at Kapilani before, as well as other in utero toxins, fetal alcohol syndrome. You notice the smooth philtrum, thin upper lip, kind of small palpebral fissures, kind of upturned nose. In patients with a variety of causes, macrocephaly causing the brain not to grow adequately. Microcephaly, sorry. Microcephaly, brain too small. And in this older case series from 2014, one might think, oh, what's the reason for this? And so in 680 cases of microcephaly, nearly a third were genetic. And I think this number is probably going to grow, and that includes chromosomal or duplication syndromes, which you can pick up on microarray, and then monogenetic syndromes, whether it's dominant type, recessive types, X chromosome linked types. So that's a big number. And then a wide variety of rare causes, but cumulatively they add into this 20%, and other presumed ones that run in families, but they've not identified yet. And so I think since this time, the testing has gotten much better. And so I would say that this genetic component is probably higher. But otherwise, other causes, known things that, whether it's stroke, HIE, placental insufficiency, medications or infection. And then things around birth, again, meningitis, encephalitis, stroke, a small percent. Craniosynostosis, so in this case, not so much the brain not growing, which is either the brain not growing or brain injured and the brain injured part not growing. In this case, the skull is fusing too early, and so it will restrict head growth and sometimes can cause increased pressure problems. And so often for this, we want to feel the sutures, and often you'll feel ridging, abnormal ridging at suture lines. And the other thing is the head will get more and more unusually shaped over time. So often with sagittal synostosis, you'll see the head kind of get more and more, they call it banana shaped, kind of scaphocephalic. And that will have a smaller volume in general, but especially when multiple sutures are involved, it can affect development because of the brain restriction, brain growth restriction. So not a common cause, but something we do want to feel the head there. And then in this case, a large portion were still unexplained, but I think a much larger portion is going to be captured in genetics with testing. So it's not, we often don't get an explanation, but to me, the genetic component must be higher now. And so there's some folks who say microcephaly is not 2 standard deviations, should be 3. I think it's kind of depending if you're kind of lump or a splitter. So definitely below 3 standard deviations, you're going to find way more abnormal cases. So there's going to be a smattering of normal patients who are in that 2 to 3%, below 2 standard deviations of the mean. And just anecdotally, there's certain ethnic tendencies. So I would say in our cross section of Hawaii, Filipino patients tend to have a little bit smaller head size, but be totally developmentally normal. And so that's just one trend, I would say. And so often, here, number 5, we got to check the parents' head size. So first, the first 2 kind of clue us in, do we already know that there's some kind of brain injury, or is it trending over time after birth? And then looking at how the head size is compared to the weight and length, and then other things that tip us off that there's going to be something else involved, whether it's dysmorphic features, other congenital abnormalities, or delays in development. Will kind of help sway us how aggressive to be with evaluation. And so actually, I think I put in the Ashwall article in references for this talk, but that has since been retired because I think it was from 2014. So, but in general, if it's more than 3 standard deviations below, then I think they need work. And so in this chart that I tried to make, green is yes and red is no. So in the in-between range, I would say, well, they're unusually small, but are they proportionate? Yes. Is parent head size also small? Yes. Then barring some other developmental problem, then there's a good chance it's familial. But if for other reasons, either if there's developmental problems or with a more moderately small head size, whether it's disproportionate abnormal development or dysmorphisms, still we're kind of coming back to brain imaging. And depending on what the brain imaging shows us, going down microarray or whole exome sequencing. On the other hand, if they're doing well developmentally, normal development, no dysmorphisms, then we might just monitor clinically until these manifest in the future, if they do in the future. So in general, these would be the main questions I think that I would say we should be asking along the way. And jumping to macrocephaly. So on the other end of the spectrum are the patients whose heads are too big. So now going off the chart, and one of the most common ones, again, benign ones that we'll talk about is benign extraaxial fluid of infancy or benign enlargement of the subarachnoid space. But in getting big head sizes, there's more possible contributing components, because in this case, if the overall head size is bigger, it could be the fluid around the brain. It could be the blood flowing around the brain or extravasated if there's hemorrhage. Could be, again, buildup of fluid within the brain, or the brain itself, and then rarely the skull, which I often don't even talk about. But so the differential for in terms of where the problem is broader for macrocephaly. And I'll go through some of them here. So again, is it tracking? How far below is it? Are we in the really abnormal range or abnormal, but there's going to be a fair amount of normal folks interspersed? Again, parental head size, super important. And so I'll just explain to parents that, it really helps to evaluate your child by seeing how it compares with your head size. And in general, an adult head size is about 55, 56 centimeters. And so when the dad or mom's head size is 60 or 61, and then they say like, oh yeah, I could never fit hats when growing up, then also that, gives us some clue that maybe it's something that's running in the family. Again, anecdotally from our cross-section of our population, often um, uh, Polynesian descent, Samoan families and Tongan families have larger than average head sizes. Again, all our head size charts are probably off some mainland US average. And so folks of Polynesian descent will often have normal development but maybe abnormally large head size. But besides seeing that parents have large head sizes or abnormally large head sizes, we want to run through the similar things that we talked about for headache concerns, ICP deficits, delays in development, and again, neurocutaneous features. And so on one hand, on this half of the page, a patient with benign enlargement of the subarachnoid space will have a head size that goes off the chart. And remember looking at the chart, and then will curve back toward the chart along the chart and re-enter it often around 3 to 5 years of age. And if they were to get imaged, you'd see this enlarged space between their brain and skull. And interestingly, their bridging veins tend to be a little stretched, you can see here. And so they can actually get subdurals with minor trauma. So we don't actually have restricted activities for them, but it's important to keep in mind for later when we talk about non-accidental trauma. If you had someone who's already macrocephalic previously, that's possible they could have some blood around the brain, usually which would remain asymptomatic though. On the other hand, patients who have obstructions for whatever reason or problems with CSF drainage, like in this case where this cerebral aqueduct is closed, will have hydrocephalus and large head size that needs treatment. And again, for these cases, if they're not having increased ICP signs because of the rate of development of increased pressure, often you'll see the head size kind of tail off away from the chart progressively. In this case, someone who with subdurals, we actually have a patient in the hospital with imaging similar to this, although their head size is not large yet. And so while a patient may have altered mental status and retinal hemorrhages due to abusive head trauma, another NAT mimic also with macrocephaly and also which interestingly can have retinal hemorrhages, glutaric aciduria type 1, which often has widened opercula here and abnormal bright signal in the basal ganglia here. Again, not something that one would be seeing without the imaging, of course, but again, both of these would be on the differential for non-accidental trauma, whether it's actual trauma versus other metabolic conditions, if there's bleeding and macrocephaly. One that's probably more common are premature babies who get IVH and then have impaired drainage of the CSF, and then all the fluid spaces start dilating compared to before because of the impaired drainage. And a fair amount of them might end up getting shunted. We also follow patients who have other causes, whether it's tumors that are obstructing tumors, taking up space, or actually tumors that are producing CSF, in this case of papillomas, and other patients who might have large cysts in their head. And so again, other causes for macrocephaly, probably abnormal development, probably increased ICP and tailing off the growth chart, also similarly tailing off the growth chart. I think in the interest of time, maybe I'll not do the neurocutaneous. Um,
I
and
think that's probably a good idea. And I do have a question for you as well. So maybe we could go over questions and then potentially save the neurocutaneous conditions for a separate day. Um, we have a couple minutes. So one question I see on here is if on prenatal ultrasound, the cephalic size is abnormal, what is the first step?
I think there might be a couple things with that. One is besides the head size, what else is enlarged? So sometimes they can see hydrocephalus, they can see tumors, they can see blood, and so a lot of it would be on the underlying cause. And then the other is about how large it is, and often if it's abnormal, they'll be trending it over time. A fair amount of time. We're not right now. Heavily we're not regularly involved in prenatal counseling, but sometimes we do get calls about prenatal findings. I would say that a fair amount of times, just in general, when there's abnormalities on fetal imaging, really got to do postnatal imaging to clarify, because there's been times when things get seen and it's changed, or um, just postnatal MRIs might show something different from what was shown before. So it doesn't, not all the time, but I guess I would say um, first step would be confirming after birth, but prior to that, also it depends on what's the underlying cause. Yeah, I'm not sure about in utero kind of surgical things. It might depend on the underlying cause in terms of prenatal treatment. Thanks for the question.
Yeah, that was a great question. I'm glad I had you on. That was one where I would have had no idea where to go with it either, and I would have equally probably consulted neurology.
Actually, good also tickling reminder is so often in the infant. So as we know, the fontanelle, very good pressure sensor, and so sometimes fontanelles can be full, sometimes they can be pulsing. As long as they feel kind of like a water balloon, all that's good and normal. We get more concerned when it gets tense and feels more like a racquetball or tennis ball. Um, but a great window into the head if we need to image. So in some of the kids with large heads will start with ultrasounds. It's so easy and non-invasive. But as they get older, that that window will close and the tissue will fibrose, and it's harder to check ventricle size or extra axial fluid size. So depending on how severe that prenatal finding is, they may just ultrasound after versus
Makes sense. Okay, you ended answering that question perfectly on time. Summer, do we still need to go over any answers before we let people go? I know we kind of peeked at some of them earlier. And
Dr.
oh,
Abi, do you have a slide of them? If not, no worries. Yeah, I'm still trying to go back and forth with IT, so no worries if you don't have any. Um, if not, yeah, it's okay.
answers for all the learning
Yeah,
questions.
for the learning questions.
Ooh, I didn't. Yeah, I
It's
didn't.
okay. No
Okay.
worries.
no, not at all.
Thank you.
We will definitely see you back in that case. At some point this year, I hope to talk about the neurocutaneous conditions, and pick your brain some more on any other topics. To be mindful of everyone's time, I will let everyone get to the afternoon part of their day. I'm seeing some love this topics, and thank you very much for the great presentation. And yes, thank you for attending as well. I agree. Thank you thank you for completing my train of thought, Dr. Abe. So we will see everyone back in 2 weeks for our sports medicine talk. Thank you so much again. Thank you, Dr. Abe. Thank you, Summer, and have a great rest of your day.
Thanks, everyone. I'll get Dr. Abe's slides up as soon as we can get them over the
Yeah.
firewalls.
And we could potentially
Thank you.
split them. I don't know if that makes sense, and take out the neurocutaneous ones for now. That way it might be easier to upload because it'll be a smaller
Sure.
Okay, sounds good.
size potentially. So we'll get them to everyone.
Thank you.
Thank
Thanks.
you
Thank you.
all.
Thanks, Summer.
Bye.
Bye.
Thank you.